Okay, so for the next few minutes, I would like to share with you our Brunei data as compared to with the Dar Global Survey, which was published last year. So Brunei is a sultanate in Southeast Asia, and it is Islamic sultanate with about 82.7% of our patients who are Muslim. Hence, it is a country where every year we have big focus on Ramadan, and of course, the Ramadan Plaza and the food that comes with it. So we are very interested, and we had the opportunity to take part in the DAR 2020 Global Survey, whereby we wanted to look at the impact of COVID-19 pandemic, which was the first wave, essentially 2 years ago, and its impact on fasting amongst the older age group, defined as age group of more than 65 in this case. So my next few slides are really sharing with you the Brunei data, which I have now in the deeper or darker blue, shaded blue, compared to the lighter blue on the right-hand side of your screen, which is the DAR Global data. We recruited 193 patients. Our recruitment was basically, for the whole of Brunei, was basically based at diabetes clinic at the Endocrine Center, Ripas Hospital, which is a tertiary referral center. Very similar to what Dr. Zanaria had mentioned earlier. As a tertiary referral center, we do see more complicated diabetes patient. Very similar to the data from the global survey, we have more female than men participating in this study. However, our population is slightly younger at 52.7 as opposed to 55.1 in the global survey. Unfortunately, we did not have a lot of data in terms of missing data. We had quite a lot of missing data where patients were unable to tell us the duration of the diabetes. And our electronic health record started in 2013. So in migration, we've lost quite a lot of information for patients who've had diabetes longer than that. I would like, however, to draw your attention to the fact that in Brunei, amongst the patients who were able to record the duration of diabetes, majority of them had diabetes for at least 10 years and more, which is in sharp contrast to what the DAR Global Survey showed, which is just over half had diabetes less than 10 years. Immediately, we're thinking, okay, that puts our patients at a higher risk for fasting as according to the risk stratification. Our diabetes control wasn't the greatest at 9.2% versus 8.4% for the global survey. And if you look at this, majority of our patients who participated actually had HbA1c of more than 9. And again, just this also tips them over into the high risk for medium risk and high risk for fasting. So drawing attention to the fact that although we have younger patients, we also have patients who have poorer controlled diabetes. Next is looking at the baseline clinical characteristics of our patients in comparison to that in the global survey. Metformin was one of the most commonly used drug. And again, as a tertiary center, a lot of our patients are on more than 2, if not 3, oral hypoglycemic agents, and some of them in combination with insulin. It is startling to see that in our population, over 60% are on sulfonylurea compared to just under 40% for the global study. And despite being on sulfonylurea, metformin, a lot of our patients are also on insulin, more premixed than basal insulin, bringing a total of 64.4%. As opposed to just over 45% for the global study. This again would also tips and increase the weightage of our patient into the higher category for risk of fasting. Our population are also having more comorbidities. Apart from diabetic foot problems, in Brunei, we see doubling of hyperlipidemia. In terms of microvascular complication, we see about 1.7 to 2 times increase, and also we see almost 2 times increase in macrovascular complications. So sulfonylurea usage is more insulin usage is more, even though we also use a fair amount of DPP-4 inhibitors. So what are the practices like in terms of Ramadan? We also took the opportunity, this slide here and table shows us only data from the Brunei population participants. We also took the opportunity to ask our participants whether they fasted the year before. So overall, the p-values were not significant for the whole tabulation of this data, and overall 96.4% of the Bruneian patients actually fasted, and they are the younger ones, obviously, as versus the older age group. Now, this is higher overall compared to the Dar global study, which recorded a 83.6% who fasted. Breaking their fast during Ramadan due to diabetes-related illnesses was 11.3% of the patients who fasted. And this is in comparison to Dar, which recorded a 12.5%. So overall in Brunei, 1 in 9 participants actually had to break their fast. And of this, 1 in 11 are the younger age group. And just like the Dar data, we have the same for the elderly or those above 65, whereby 1 in 5 had to break the Ramadan fasting due to DM-related illnesses. Despite all that, the mean age of fasting was 25.4, which is in line with the global study. In terms of complications of diabetes, we did not record any case of HHS or DKA. But hypo and hyperglycemia during Ramadan was definitely there, 7.2% overall for the hypoglycemic figure versus, which is more in the elderly than in the above 65 than in the under 65. Interestingly, of the under 65, every single participant over 65 of age had to break the fast because of hypoglycemia. We recorded very few hyperglycemia, only 3.8% overall. And in terms of the necessity of them to either attend the emergency or to be admitted, we had 1 who is above 65 requiring attendance to emergency, not admission. So that brings us to about 4.8% versus the 6.6% in the Dar global survey. Although we had only had 1 patient who recorded hyperglycemia, this particular patient recorded hyperglycemia for a long duration of 14 days during Ramadan, but did not necessitate bringing the patient herself or himself to the emergency services. Very similar to Malaysia, and I'm glad to hear that because I was looking at this data and I thought, oh my goodness me, the percentage of our patients who does self-monitoring at home was only 28.5%. So not that many patients were actually checking the blood glucose at home. And in fact, there were a few patients who actually says they had home blood glucose monitoring kits, but they were actually recording less and not more during the month of Ramadan. Unlike the Dar Global Survey, we had a 72.1% of patients who told us that they received education. And for this, we're very pleased to see. And unlike the Dar Global Survey, majority of the education came from our nurse educators. So at this point, I'd like to thank all the nurse educators in our clinic for helping us, the doctors as well, in counseling patients about education and Dar. Unfortunately, our dietitian seems to be lower down in the ranking for receiving. We had patients telling us that they received other ways of receiving education via leaflets, and in fact, 1 even received education from a family member. So in summary, I just want to go through what are the pertinence, the differences in the fasting in Brunei versus the global region. One is that our patients is slightly younger, with longer duration compared to that for the global survey. Our mean HbA1c was higher, and majority of our patients are on sulfonylurea. And also over 60% of our patients or participants were on insulin compared to just 43% in the global survey. Most of our patients had some forms of complications, with 61.6% with microvascular complications and about 20% with macrovascular complications. So all this again would increase the weightage of fasting. Yet we have over 90% of our patients who chose to fast, and over 95% managed to fast for at least 9 days. Although only 51.6% managed to complete a 30 days fast. I think that one of the other reasons why only 51.6% completed a full 30-day fast as versus the 61.9% was that our participants, we had much higher proportion or percentage of participants who are female and of the younger age group of under 65 as well. And that may have tipped the reason why the fasting dates are slightly percentage of complete 30 days is less. 70.2% higher percentage of patients reported hypoglycemia, which in a way perhaps it's not surprising given the rate of use of sulfonylureas and insulin. So the incidence of hypoglycemia is 20.6% in those over 65. And what was startling for us was that all the participants, not many, only about 34 participants, but every single one needed to break their fast during Ramadan. And their hypoglycemia tended to occur between 9 a.m. in the morning to noon, unlike those in the under 65 years of age, whereby the hypoglycemia pattern tends to be towards pre-iftar, which is what is shown globally. So in terms of our Ramadan-focused education, we know that Ramadan-focused education is essential in order to provide a safer fasting for our patients, especially our very of medium and high-risk patients. And we were glad to report 72% of participants in our survey actually received education, compared to 43.5% of the participants in the Dar 2020 global study. However, majority of them received it from our nurse educators, followed by doctors and then the dietitian. So in conclusion, I'd like to say that despite our group of patients who are at high risk for fasting, the rates of Ramadan fasting amongst them remains high and is very similar to those before COVID pandemic. Glycemic complications were seen to occur more frequently in the older adults, necessitating all participants to actually break the fast. So as alluded by Dr. Muhammad Hassanein, there is a huge emphasis that we need to do the risk stratification for our patients, the upcoming Ramadan, do formal pre-Ramadan assessment and medication adjustment prior to Ramadan, especially for those in sulfonylurea and insulin. And all this as concluded by the Dar 2020 study is that this is essential to promote and strengthen a structured approach to Ramadan-focused education and self-monitoring in order to ensure safe fasting with an aim to prevent complications. So I'd like to end by thanking my team, especially Dr. Adiba and Dr. Nina, as well as all the doctors and the DNEs who helped recruit patients at Endocrine Center. And also I'd like to thank Dr. Muhammad Hassanein and especially also to Dr. Zanaria for inviting us to participate in this study. Thank you. I'll be happy to take any questions after this. Thank you.